In the world of emergency medicine, there are high-stakes decisions. And then there's this one, epinephrine. It's an absolute game changer, a life-saving drug. But a simple mix-up between its two common concentrations, that can be catastrophic. So today, we're going to break down exactly how to get it right every single time.
So yeah, that's the big question, right? How can the exact same drug be the hero in one scenario and the villain in another? Well, it all boils down to concentration and the route you give it. Let's dive in and make sure you know exactly what to do to prevent a disaster. To really get why this is so critical, let's just jump straight into a real-world case. This is one of those situations that tragically shows just how devastating a simple error can be.
This case is just a gut-wrenching reminder of what's on the line. Imagine this. A 2-year-old kid in anaphylactic shock accidentally gets the super concentrated intramuscular dose, but it's given directly into a vein. The result is instant, an immediate cardiovascular crisis. We're talking a heart rate of 180 and dangerously high blood pressure, all from a completely preventable mistake.
Okay, so what's the deal? Why are these two so drastically different? It really just comes down to decoding the concentrations. It's all in the math, and it's simpler than you think. And here it is, laid out plain and simple. That 1 to 1,000 epinephrine, that's the strong stuff, the more concentrated version. It has 1 milligram of the drug packed into just 1 tiny milliliter of fluid. Now the 1 to 10,000 has that same 1 milligram of drug, but it's diluted in a full 10 milliliters of fluid. So same drug amount, just 10 times more watered down. That's the key difference.
You might be wondering, why on earth are we still using this super confusing ratio system in the first place? Well, it's basically a historical fossil. Epinephrine's labeling is so old, it actually predates the 1938 Food, Drug, and Cosmetic Act. And somehow, this old-school format just stuck around, creating this huge potential for confusion, especially when things get chaotic.
And that confusion? It's not just theoretical, it's dangerously real. A survey of hospital physicians found something that should honestly stop you in your tracks. 50%. Let that sink in. 1 out of every 2 doctors couldn't correctly convert an epinephrine dose from the ratio format to a standard mg per ml concentration. This isn't just some trivia night knowledge gap, it's a huge systemic risk that tells us we need to be crystal clear on this.
Okay, we've seen the risks, we understand the confusion. So how do we make sure we get it right every single time? Well, it's all about matching the right tool to the right job. Or, in this case, the right concentration and route to the right emergency. This table right here, this is your go-to guide. For a kid in cardiac arrest, you're grabbing the diluted 1 to 10,000 and giving it IV. For anaphylaxis, you're using the concentrated 1 to 1,000, and listen up, this is key, it goes intramuscularly, in the muscle. And for bad croup, we use that same concentrated 1 to 1,000, but we nebulize it. So you see, 3 different emergencies, 3 very, very specific playbooks. All right, let's zero in on cardiac arrest. The whole point here is to get epinephrine into the bloodstream to kickstart that heart and get blood flowing to the brain. Using the more diluted 1 to 10,000 form is absolutely essential here because it's safe enough to go directly into a vein without causing a whole new set of life-threatening problems. And this is why putting that concentrated 1 to 1,000 stuff straight into a vein is a massive no-go. It's just way too powerful for direct IV circulation. It'll cause insane vasoconstriction, put a crazy amount of strain on the heart, and can easily trigger deadly arrhythmias or spike blood pressure into the stratosphere. It's a recipe for disaster. All right, so let's flip the script. When do we use that concentrated 1 to 1,000 solution? Well, for anaphylaxis and croup, that's your go-to. But for these, the route you give it is absolutely everything. For anaphylaxis, we're going deep into the thigh muscle for super fast absorption. For croup, it's nebulized into a fine mist so the patient can breathe it in and it can work directly on that swollen airway. See the common thread here? In both cases, we are staying far away from a direct IV line. Let me say that again. 1 to 1,000 never goes directly into a vein, period.
Okay, so here's a super common scenario. You're in a code, you need 1 to 10,000 epi now, but all you have is a vial of 1 to 1,000. You have to be able to make what you need on the spot. This skill, being able to do this dilution, it isn't just useful, it's absolutely critically life-saving.
And the process is actually pretty simple once you've got it down. You're just going to take 1 milliliter of that concentrated 1 to 1,000 solution and add 9 milliliters of normal saline. Boom! You've got a total of 10 milliliters of the correct 1 to 10,000 concentration for IV use.
And that last step on the slide, labeling, yeah, that's not optional. That's probably the most important part of the whole process.
So let's walk through it. First things first, you carefully draw up exactly 1 milliliter of that concentrated 1 to 1,000 epinephrine into a 10 milliliter syringe.
All right, now for the magic step. Into that same syringe, you're going to draw up 9 milliliters of normal saline. This is that crucial dilution that makes it safe to give IV.
And there you have it. That's your final product, a syringe with 10 milliliters of 1 to 10,000 epinephrine ready for a code. But look closely. That label is your best friend. It's the vital safety check that prevents a fatal mix-up.
Okay, let's lock in these critical rules so they become muscle memory. We've got a simple little saying to help and then a final safety checklist.
So for anaphylaxis, just remember this. Less is more. You're using less volume, like half a milliliter, of the more concentrated 1 to 1,000 solution. And it's going IM.
And for cardiac arrest, you just flip it. More is less. You're using more volume, a full 10 milliliters, of the less concentrated 1 to 10,000 solution, and it's going IV. Finally, this right here is your safety net. Make these actions a habit every single time. Verbally confirm the concentration and the route with a colleague. Double-check your dose math. Make sure your crash carts are ready for both situations. And I know I sound like a broken record, but label every single syringe. No excuses.
So I'll leave you with this challenge. Knowing how easy it is to get this confused and knowing the devastating consequences, what's one real, tangible thing you can do this week to make this distinction safer and clearer where you work? Think about it, talk about it with your team, and then go do it. Thanks for joining this explainer.